Okay, moving on to this, um, I guess we would call it another invisible wound of war, the misuse of alcohol. And so the sample that she is describing in this textbook, when she reports research related to military misuse of alcohol, is actually a 2011 study of members of the National Guard. I think it was maybe 600 or 700 or 800 people, and it was probably survey research, if I had to guess, about misuse of alcohol as a not very functional coping mechanism. And one study, in this particular study, I think the occurrence rate was as high as 36%. Again, that's pretty high, right? And when we have stress and anxiety, we do definitely try to lessen that. And we do it in healthy ways and unhealthy ways. You guys, we've talked about this lots of times in class, and we actually talk about, when we're offering crisis intervention, giving education and therapeutic statements and recommendations to clients about how to manage sadness, stress, loss. Every one of the topics of our chapter actually involve us trying to help clients use and develop effective coping mechanisms to be able to live with the crisis that they're currently experiencing. So this misuse of alcohol is a negative thing that can arise, and again, kind of relating to this study for these National Guard members, so if 36% of them reported misusing alcohol. I'm not talking now, I think it's careful, we got to be careful. We're not talking about alcohol addiction necessarily. We're talking about misuse of alcohol. And so if 36% of those people, respondents, said, yes, I've misused alcohol in order to cope with my stress, my anxiety, my rage, my fear, all of it. 31% of the people in that study reported that they had received some mental health treatment from probably VA centers, I'm guessing, but could be all over, who knows. But 31% of those people had received some mental health service. That's a really high number. If you're talking about 36%, illustrating a problem or experiencing a problem, and 31% of those people receiving some form of help, that's pretty darn good. However, in this study, only 9% of those people, that 31%, only 9% of those people received specialized treatment that's related, specific to alcohol misuse. And so, this is interesting. There's some discussion in the textbook about this. Oh, wait, you know what? I think I misspoke. I'm looking at my notes, and it's 2.5% out of that group said that they received treatment specifically for alcohol misuse. And so, or a substance use disorder, we would use that phrase. That's not a very high number. It's suggested in this discussion in the text that maybe the reason people don't go for that particular kind of treatment is that they're fearful of that being reported in their service record, and they reasonably wonder if and believe that this could be something that would stop them from getting a promotion in rank. And this is true really across the board for people who aren't military service members, being fearful of this. It also, just goes along with the whole understanding we have that in general, people in the military, the historical view of receiving mental health assistance is, that soldiers don't do that soldiers don't have mental health problems, that warriors don't get PTSD or depression or feel suicidal. And luckily, in recent decades, that kind of, cultural training is lessening to some degree, not completely gone for sure. So it does appear that the reason that people don't seek assistance for substance use disorders is because of that stigma, really. A good reframe for this is for a crisis worker to offer up the idea that, well, the fact that you're misusing alcohol is really, could be related to a physical health risk. And so instead of it being a weakness or something to be ashamed of, it can be talked about with a crisis client as something that is really kind of bad for their physical health. And maybe a client would be more willing to talk about that and receive treatment for that if they're thinking about it in that manner as a risk for wellness. There's a pretty big connection, as you probably know, between the misuse of alcohol and suicidality, because alcohol is a depressant. It has that effect on our body, our functioning. And so if a person is already using alcohol to numb terrible feelings and terrible memories and flashbacks and nightmares and agitation and all kinds of symptoms like that, it's not too far down the road for a person to maybe develop feelings of suicidality, that just living like this is not worth it, and maybe the best thing to do is to check out. So these are all important, what the book refers to as invisible wounds, and I would hope that you would, as we study this chapter, that you would think about them in this way. And so now I'd like to move into treatment for all of these invisible wounds. What do we do? What are good treatment modalities for people who are living with these kinds of effects from their military service specifically? So let me just move on, because I kind of said that out of my notes. There are some factors to remember. One of those is keeping in mind the client's feeling of safety. Also, you want to think about and wonder and try to work with the client to make sure that if we suggest services, that they can actually get to services. If I were working in the counseling center at Sandhills, for example, or if I were the veterans counselor at Sandhills, I would very much make myself familiar with the VA and Veterans Affairs and the use of their insurance at private practices, and I would just want to know everything about how to get my client to services that they need, so that when they ask me about it, if they're willing to go, I know the facts about where to send them. And this is the kind of thing that you just have to develop after you get out of school and you're working with people. You start to find out what else you need to know and what practical information you need to know. So tuck that in your pocket as an idea. The main option for treating these invisible wounds is really a two-pronged approach. It's counseling and or medication. So it might be counseling of some sort or therapy of some sort by itself, or it might be that the person's having such disruption that really for a while medication is something that's really needed. And so we're going to talk a little bit about some of the treatments that are therapy oriented. I won't talk very much about medications because I'm not an expert in that, but it's very important for you to realize that using medication shouldn't be something that we necessarily frown on. And actually, often medication in conjunction with counseling interventions is the very best approach, the most effective evidence-based approach, really. So the medications, I'll just say that generally might be, there's a list of them in the textbook. I don't think I made a page reference for this, but the medications that might be prescribed would be those that are helpful for anxiety and also those that are helpful for depression. And so antidepressants, anti-anxiety medications might be the kinds of things that a psychiatrist would prescribe based, of course, on the kind of symptoms that a client's having. If counseling is the choice, there are lots of forms of counseling that can be very helpful specifically for this kind of client. Cognitive behavioral therapy, or CBT, is one of the families of therapy that can be quite useful. In the textbook, there's a very light description of the forms of cognitive behavioral therapy that have to do with exposure therapy. And when you hear that phrase, exposure therapy, you should understand that this is a form of therapeutic intervention that is related to having the client re-experience the traumatic event or events and do some things that help them with relaxation and less reactivity. This is highly specialized training done at the master's level for sure, and would need to be very carefully guided. So she doesn't really go into a lot of detail about what that is, but that is what that is. Also, she mentions stress inoculation training, and this is something that you might learn more about as you move into your bachelor's programs, if you decide to do that, or certainly in a master's program in counseling or social work or psychology, you'd learn about stress inoculation. And so if you think about an inoculation as a shot, that you would get a vaccination against something, stress inoculation is the training of a client in using stress management techniques so that they have some protection against anxiety, and they have some techniques that they can call upon to use. And so things like teaching a client about guided imagery would be helpful there. Progressive relaxation training would be helpful with that. Using the breath for relaxation. Role playing, we've done some role playing even in this class, and guided self-talk. All of these are particular techniques that you can train a client to do, that when they start to feel anxious or out of control, they can use these for themselves to lower their reaction to the anxiety. I wanted to talk a little bit about a couple of things. There is a clip embedded in our Moodle page for this chapter on virtual reality and how virtual reality is now being used to help clients, former military clients specifically, re-experience trauma and then relax. And so I would suggest at some point when you're studying this chapter that you open up that clip. It's probably between 5 and 10 minutes long, and it's a great example of a military service member who's receiving virtual reality training, and there's some discussion about how this works. But one of the powerful things in that clip is that you get to see the gentleman, the guy who's using this therapy, and how reactive he is, and how his startle reflex is quite elevated, actually. Let's see. I've mentioned EMDR to you before. This is another one of those therapies that requires extra training and certification, actually, to help a client with. But it is another one of those exposure therapies that is meant to reduce anxiety and reactivity to anxiety and trauma, particularly trauma. Let's see. So I've talked about just anti-anxiety and antidepressant medications. It might be good for you to understand at least a little bit about how those medications work and why they're prescribed. I think there can be some real misinformation out there about how medications work and how long it takes for a medication to actually become effective because of the brain chemistry involved. And I think that's something that's worth you learning a little bit about if you're going to be working with clients, and then talking with them a little bit, just basically about medications. In general, best practices for PTSD and helping clients with PTSD. Hold on, I'm going to check the camera. Yeah, we're still going, and we're at about 15 minutes. In general, best practices include educating the client about how PTSD develops, how it is a stress reaction. In our prior chapter, we had a whole really big discussion about this, but for military service members, this would be an important aspect to make sure that you cover. It could be, part of the educational statement intervention that you might use if you were helping somebody understand that if they just got a diagnosis of PTSD, for them to understand more about it and have a chance to talk and ask questions more about it. Also, best practices include teaching a client cognitive behavioral techniques. And I mentioned those just a little while ago, but it's important for you to understand that that's one of the favored evidence-based practices that it's used. Additionally, encouraging the client to make use of support groups is really helpful as well. The thing about support groups is they are set up so that you're with people who are experiencing the same thing that you're experiencing. And so when you sit down in a support group and you're talking about something, the person next to you and the person next to them and the person next to them have some variant of the same concern. And so hearing these stories, hearing other people's reactions, hearing about other people's experiences, and then also just being, supportive and providing support to others is just so therapeutic, really. It's something I think that should almost always be included as a suggestion. Also, I don't know if I said this, but in support groups, sometimes you might hear another person talk about a way that they dealt with their stressor or their situation that could be really helpful for you to try out. And so that's another aspect of support group work. All right, I want to just quickly, it's starting to rain, so I'm going to quickly talk about the invisible wound of traumatic brain injury. And TBI has become a common war wound, especially for these most recent war theaters. I talked before about IEDs and RPGs and roadside bombs, those sorts of things, because they cause very, from mild to very serious concussions. And these concussions are, where your brain is moving around inside your skull, and it can be damaged by this concussive experience. And so, brain functioning actually gets altered with a traumatic brain injury. Traumatic brain injuries can also happen from falls and from car accidents, but of course right now we're just talking about military service members. I did find an interesting clip, I think, about the, might be an article actually, about the neurological changes that can happen for a person who has a traumatic brain injury. But what can happen, and what that feels like for a military service member is a set of symptoms. And so these symptoms can include memory loss, impaired concentration, decreased levels of consciousness, and other neurological irregularities. And these can begin, fairly shortly after the injury, but then some of them actually progress and can cause dementia and even the development of Alzheimer's in some rare cases. So traumatic brain injury is a very specific and serious matter that, or I think requires a lot of compassion. We've had many service members come to Sandhills. I've had them in my classes in the past who have traumatic brain injuries. And so for being in a college classroom, there are some, effects that a person would have. And when you think about concentration, a person who has a traumatic brain injury might not be able to sit and listen to a lecture like you are right now and take notes like you are right now. They might need, shorter bits of information given to them. And they might need things to be presented to them in a slower fashion. And I'm saying this to you because if you're, helping someone in a crisis intervention and you're trying to teach someone something like relaxing breathing or grounding, for example, you might see that with somebody with a TBI that you need to slow that instruction down and simplify the directions so that the person can actually take them in. Otherwise, I can only imagine how, frustrating and upsetting it would be to be a person with a TBI who's trying so hard to concentrate and help themselves, and because of the injury and their lack of concentration or their impairment in concentration, they're not able to take advantage of what you're trying to teach them. Let's see, I guess I wanted to stop the lecture right here, and then I'll pick this back up for us on Wednesday. Thank you.